Perfect.
Can you see it?
Yeah. Awesome.
All right, good morning.
Dr. Anderson, thank you so much for joining us. Again, Dr. Anderson is one of our amazing faculty at Columbia. Did his residency in Nashville at Vanderbilt, came up to New York City for fellowship at Memorial Sloan Kettering, and is now at Columbia, where he's an assistant professor of urology, focuses on urologic oncology. Dr. Anderson, I mean, a bunch of us have already asked you within the program, your interest in urology and how you kind of narrowed down on urologic oncology. But for everyone listening out there, what was your path during residency? Dr. Himes talked about mentorship. Were there any mentors, or were there any experiences in residency that kind of ultimately pushed you or kind of directed you into urologic oncology specifically? Kind of like, how did you end up where you are right now?
Yeah, I think I would echo a lot of what Eli was saying. I think, I was able to have really great mentorship as a resident, and the people who I kind of collided with along the way and worked with really shaped my interests and, helped me make decisions along the way and kind of led me to where I am today.
Great. For those of us, kind of nearing applying for fellowship in urologic oncology, I guess in the days of like open surgeries kind of decreasing and minimally invasive increasing for urologic cancer cases, what would you recommend, for those who are a little bit worried about maybe not having or applying to places that may not have that open experience? Should there be any concern of that? Should they change their mindset, or should they, look a little bit more in depth into, places that may offer both still?
Yeah, that's a hard question. I mean, I think that's something that many residency and fellowship programs are struggling with, which is, is it still important to provide a balance in surgical approaches? And if so, how do you accomplish that? Clearly nowadays we're getting better and better at doing minimally invasive robotic and laparoscopic and endoscopic approaches for even bigger and more challenging cancer cases. So, which is great for our patients, but then it does take away some of that open experience from the residents and fellows. So, I was fortunate to have a lot of that experience when I was a resident. And I don't think that open surgery is going to go away completely. Certainly here at Columbia, we still do a reasonable amount of open surgery, and I think that it is important to get that exposure, especially if you plan to be doing cancer cases and especially bigger cancer cases.
Yeah. Okay. Well, thank you so much again. Thank you for being with us. I'll pass the torch on to you, and then for anyone who has questions, please just post them in the chat, and we'll try to get to them with Dr. Anderson at the end.
Great. Well, it's great to be here with you guys today. Hope everyone's doing okay. I know this is a tough time. And thanks for Miad and Mike and Gina and everyone else, and Alex who's helped organize this lecture series. So today I wanted to talk about stage 1 germ cell tumors. I think that, as a resident, this was certainly something I didn't get a lot of exposure to, but was heavily tested on. And so a lot of what I was learning was from prior tests and from summary statements and articles and so forth that I don't think I fully grasped until maybe I got to my fellowship, where we took care of a lot of testis cancer patients. So, hoping to unpack some of the evidence and the studies and the data that kind of support the current treatment options and the current recommendations about management of these patients. Importantly, this is like, I guess, treating localized prostate cancer, where there are many right answers. And so knowing what the different options are, the risks and benefits and so forth, are going to arm you all with the ability to have this sometimes difficult conversation with patients and help them make a decision. So I have no disclosures. I want to do a brief outline and really kind of get to points number 2 and number 3 quickly. There's a relatively dense talk out of necessity, and so I want to try to get through as much as we can. So testicular cancer, a little fewer than 10,000 new cases a year, about 440 deaths, most common in young men, and many testis cancer survivors. So last year there were just shy of 300,000 testis cancer survivors in the United States alone. So when you talk about germ cell tumors, there's really seminoma and non-seminoma. The numbers break down such that a little over half of new diagnoses for seminoma, they tend to be a little bit older, so patients tend to be in their 30s and 40s, but most of the seminoma diagnoses are clinical stage 1, whereas for non-seminoma, patients are a little bit younger and only about a third are clinical stage 1, so many patients present with distant disease at diagnosis. Importantly, for patients with clinical stage 1, whether it's for seminoma or non-seminoma, the survival rate is almost 100%, which is why this is such an important talk and concept, because it's really about trying to find the best treatment for the right patient to minimize some of the short and long-term side effects that we'll go on to discuss. All right, so we're talking specifically about clinical stage 1, and so we're going to just review staging real quick. Whenever you see a patient with a suspicious testicular mass, first of all, you always want to get a scrotal ultrasound. There's a very low but not insignificant risk of a contralateral germ cell tumor, so you want to know if that's present. You would establish the T stage through a radical orchiectomy. The T stage is listed here below. The tumor markers, the testis cancer is unique that it uses tumor markers in the staging system, and the 3 tumor markers listed here need to be post-orchiectomy. So you establish your S stage post-orchiectomy. That's the T1 half, the half-lives of the 2 markers are listed here. This is very important. We'll get back to this in a second, but AFP, half-life of 5 to 7 days, HCG 2 to 3 days. Cross-sectional imaging is used to establish the N and M stages. So here are the nodal stages for patients with retroperitoneal lymph nodes. And then as far as retroperitoneal lymph nodes, there's this concept of the primary landing zone. So, really right-sided tumors kind of congregate paracaval, precaval, interaortocaval. Left-sided tumors are para-aortic and interaortocaval. And the lymphatic drainage goes from right to left. So it's a pretty common test question that we've seen in the past. So it's important to know the primary landing zones and to know how the lymphatic flow can go on testis cancer patients. And there's a lot written about, well, what is suspicious, what is an enlarged lymph node. I think that your level of suspicion, has to vary based on the clinical scenario, but really anything that's greater than 5 millimeters could be considered suspicious in the right clinical context. So what we're going to talk about today, these are the different stage categories, and we're going to talk specifically about stage 1A and 1B. So these are patients who have no lymph node metastasis, no distant metastasis, and normal tumor markers. This does not include, importantly, this does not include stage 1S, which is patients who have no visible metastasis but elevated tumor markers. That's a totally different set of patients, and those patients all get chemotherapy. So this is only for patients with negative markers, negative nodes. So we're going to start with a few cases. It's a really fun game called Clinical Stage 1 Testicular Cancer Jeopardy. If you were here in person, I get to call on a few guys, but I'll do it here by myself today. So the first patient is 23 years old. He has a mixed germ cell tumor. He has a chest, CT, abdomen, pelvis that are negative, and his pre-orchiectomy tumor markers are significant for elevated AFP. At 2 weeks post-orchiectomy, you see his markers listed here as his AFP is still elevated. So the question is, does this patient have clinical stage 1A or B testis cancer? Would you treat this patient with chemotherapy because his AFP is elevated or not? Hopefully you're all thinking, I would not do that. I would wait and check his AFP again because I know his half-life is 5 to 7 days. And in fact, this patient's AFP went down. So, lesson number 1 is always make sure you continue to trend your tumor markers and figure out where they're going to nadir before you pull the trigger on establishing a stage and treatment. This is a 39-year-old male with a seminoma who had normal markers and a negative chest imaging. And this was an outside radiology read, and it was sent to you, and it was reported no pathologic adenopathy. And it's really important that as urologists and surgeons that we're reading our own scans. And so I took a look at this patient's scan and had it reviewed here by our radiologist. And in fact, in the primary landing zone on this patient with a left-sided tumor, there's about a 1.2 centimeter para-aortic node. So I would say that this patient does not have clinical stage 1 testis cancer, even though he was referred as such. Patient 3 is a 31-year-old male who has a T2 mixed non-germ cell, non-seminoma. His markers are negative, and his CT shows that he's got a 7-millimeter mesenteric lymph node with no other abnormalities. So does this patient have clinical stage 1 disease? You know, a mesenteric lymph node is really not in the primary landing zone for any germ cell tumor. So I would say that this is an incidental finding, and I would classify this patient as clinical stage 1. And then the last patient here is a gentleman with T2 seminoma. He had negative imaging, and his pre-orchiectomy tumor markers demonstrated an HCG that was elevated to 25, and about 10% of patients with seminoma can have an elevated HCG, so he was one of them. 3 weeks post-op, his markers were normal. Does this patient have clinical stage 1? Yes, he does. His markers are negative, his CT is negative, and he has clinical stage 1. So this is a talk I've been giving for the past few years. Just since last year, what's new? Well, we got the guidelines last year, sometime in April, which were tremendous. They did a great job with the AUA guidelines. There was 1 or 2 papers that updated active surveillance, and then also an update on adjuvant BEP that we'll review. So I want to dive in now to non-seminoma. So there's basically 3 options for patients with clinical stage 1 non-seminoma: either surveillance, primary RPLND, or primary chemotherapy. The disease-specific survival is just shy of 100% for each of these options. And depending on where you live in the world, you might be recommended to have one or the other, and we'll see how that's reflected in some of the guidelines. But the key is to try to minimize treatment morbidity and to minimize over-treatment. So what are some unique features of non-seminoma that might help inform your decision to how to treat a patient with clinical stage 1 disease? First of all, non-seminoma has teratoma, and teratoma is both chemotherapy and radiotherapy resistant. Number 2 is that we have a reasonable ability to predict who is at high risk of relapse or having micrometastatic disease based on some clinical characteristics. And then the third important unique feature is that non-seminoma is not very sensitive to radiation. So one option for treatment of non-seminoma is active surveillance. The benefit of active surveillance is that up to 80% of patients with clinical stage 1 disease are cured by orchiectomy alone. So if you watch everybody, you avoid unnecessary treatment in 80% of patients. You avoid the overtreatment. And for patients who do recur on surveillance, there's a very high salvage rate. It's very rare to have a death from recurrent non-seminoma on surveillance. The risk, though, is that this does have the highest risk of relapse. Depending on the risk of the patient, anywhere from 20 to, say, 40% of patients will relapse on surveillance. When needed, salvage therapy for patients who recur usually requires full-dose chemotherapy. I'll tell you what I mean by usually in a little bit here, but a higher chance of needing 3 or more cycles of BEP or EP. And you definitely need imaging, and there's a risk, this risk of loss to follow-up, and that's bad, and this is definitely not a good treatment option for patients who might not follow up. So just to summarize, little bit less than 30% of patients overall are going to have a relapse on active surveillance. The risk of death on active surveillance is about 1% of death from testis cancer. Most of these recurrences are early, so within 6 to 8 months. The retroperitoneum is the most common site in maybe 60 to 70% of patients. Most of these, again, relapses occur early, and it's pretty rare to have a relapse after 5 years. Now, we talked about risk stratification. There's basically 2 characteristics that have been used to risk stratify patients with clinical stage 1 disease. One is the presence of lymphovascular invasion, and the other is the presence of embryonal carcinoma. So lymphovascular invasion is probably the most replicable and most reliable clinical factor. And in a recent meta-analysis, compared to patients without lymphovascular invasion, those with it had about a 4-fold increased risks of developing of recurring over time, and this translated to about almost a 50% risk of metastasis. Embryonal carcinoma, there's been many different ways that people have categorized this. Having any embryonal carcinoma, having pure embryonal carcinoma, having at least 50% embryonal carcinoma. So there's been a bit of inconsistency across the literature, but again, this meta-analysis would suggest that patients who have at least 50% embryonal carcinoma have a little more than twofold increased chance of having metastasis, which translated to about a 40% absolute risk. So I want to talk about a couple of important surveillance studies that have been done that really kind of show us what to expect when we put patients with non-seminoma on surveillance. This is a Danish cohort. It was published in 2014. And there are over 1,200 patients with clinical stage 1 disease who were put on surveillance in a non-risk stratified fashion. So anybody who had any amount of cancer, whether it be LVI positive, embryonal, predominant, anything, were all put on surveillance. The 5-year risk of relapse is about 31%. Almost all of these patients relapsed with good risk disease. This is, again, the ICGGC risk metastatic disease risk stratification system that most of these patients had good risk disease, meaning they had a very favorable prognosis with salvage chemotherapy. About 4% of these patients were lost to follow-up, and that was bad. But overall, fewer than 1% of patients actually died of testicular cancer. And you can see here on the right, most of the recurrences happened early on. The bulk of them were in the first year. Most of them were detected with either CT scans and or tumor markers. And then this here to the left shows that some patients were at relatively low risk, whereas some patients were at much higher risk, and that is depending on the presence of embryonal carcinoma and or lymphovascular invasion and or reedy testes invasion, which is typically used to classify seminoma patients, but here they actually used it for non-seminoma. Another important study was a multi-institutional cohort, also published in 2014. This was almost 1,200 clinical stage 1 patients. It's a little bit of a lower risk cohort. Only 16% of them had lymphovascular invasion. And you see that translated into a lower risk of relapse, about 19% relapse. But the LVI positive patients had a 44% chance of relapse, and the LVI negative patients had a 14% chance of relapse. So you see there, that's a very important risk classifier. Most of the relapsers were good risk. And again, most of these relapses occurred early on, were detected with CT or tumor markers, and less than 1% of patients died from recurrent non-seminoma. So then the question is, well, what happens? Let's say you treat a patient on surveillance, and what happens if they recur? Well, many studies would recommend treatment with full dose chemotherapy, depending on their metastatic risk strata. This is an interesting study that was published last year from Canada. And they have a policy here where if you relapse, the management for a relapse on surveillance could either be chemotherapy or RPLND, depending on the volume of disease, the presence of markers, et cetera, which are kind of listed down here. Of the 580 patients who, all comers, non-risk adapted, who were put on surveillance, 162 relapsed. Most of them were good risk. Most of them were in the retroperitoneum only. And what you can see here is that about 40% of them who did relapse got an RPLND, almost 60% got chemotherapy. And the majority of patients treated with these two different scenarios, these two different treatment options, were cured by that option alone, but a handful required the second treatment option. And of the relapsers, 4 died of disease. That equated to 2.5% of relapsers, or about less than 1% of the total population. So they would argue that by using chemotherapy and RPLND to salvage patients with relapsed clinical stage 1 disease, that you can avoid the amount of patients who require full dose chemotherapy. You can kind of minimize the number of patients who have RPLND compared to immediate RPLND for everybody. And overall, the patients receiving any chemotherapy is lower than giving all patients who relapse salvage chemotherapy or giving everybody BEP. So this is kind of like the talk in a nutshell, which is the different trade-offs between all these different treatment approaches. But they would say that using RPLND sparingly for a select patient would help avoid salvage chemotherapy and may be a preferable option as opposed to treating every relapser with full dose salvage chemo. So here are the current guidelines, recommendations for surveillance of non-seminoma. You can see here that you see the patient several times a year to get markers and do a history and physical. CT scan is used, primarily within the first 2 years, several times a year, and then annually thereafter, as well as chest X-rays. Many of the hospitals now are using low-dose CTs, and there's studies out there about whether MRI would be a reasonable replacement. I think there's a lot of interest in some of this microRNA that's been published on over the past few years, and maybe that's a better prognostic marker than imaging or markers. So more to come on that. So some of the concerns about surveillance, as we talked about before, non-compliance, probably less than 5%, could be higher in community centers, and patients who are non-compliant with surveillance do have a risk of dying from cancer. And that's an important part of your conversation when you see these patients. Although it be unlikely, it's still higher than compliant patients. And then the other question is, well, if you're scanning men multiple times a year, are you actually going to be putting them at risk for secondary malignancies due to ionizing radiation? And this is a modeling study from about 10 years ago that suggested, yeah, I mean, the more you scan patients, there's going to be some risk associated with that in secondary malignancies. Now that we're talking about using low-dose CT, it'll be interesting to see how that changes the risk, but definitely a risk that you have to discuss about active surveillance. There was a study published a little over, 13 years ago that asked the question, can we do fewer CTs for patients on surveillance? This is a good test question, which is why we're talking about it. So this study randomized patients to either a CT scan at 3 months and 12 months or multiple CT scans up to 24 months. And this is a relatively low risk group. Only 10% of the patients had lymphovascular invasion. And the primary outcome of this study was a relapse with intermediate or poor risk disease. And really they found the two different methods to be non-inferior, that a 2-scan method was non-inferior to a 5-scan method. Overall, you detected just a tad more recurrences with the 5 CT method, but this was not statistically significant. And they actually didn't detect any recurrences of the 24-month CT. So, there's some questions about this study and different numbers of scans in each group, and they stopped at 24 months. It may have been underpowered. But point being is that scanning a patient every 3 months or 4 months for years and years is probably unnecessary. All right, so let's talk about option 2 for patients with non-seminoma, which is a primary RPLND. So because the retroperitoneum is the most common site of disease, and high-risk patients have an upwards of 30% chance of having positive lymph nodes, there is a rationale to do an immediate surgery for patients who have high-risk clinical stage 1 non-seminoma. Again, the rationale is that up to 30% will have viable germ cell cancer. Anywhere from 15 to 20%, 25% of patients will have teratoma, and that's been well replicated. The results of RPLND in well-selected patients are good. So about 90% of patients with low volume nodal metastasis are cured with surgery alone. There is a risk of systemic relapse, but very rarely in the retroperitoneum, hopefully never if you've done a good job. Patients who do relapse are almost always salvaged with chemotherapy, and fewer than 1% of patients who are treated with primary RPLND will ultimately die from testis cancer, which is almost identical to the active surveillance groups. So benefits of RPLND, you don't need imaging because you've pretty much cleared the retroperitoneum. In experienced hands who are offering nerve-sparing surgery, the morbidity of this procedure is low. And the downside is you clearly need to have an experienced surgeon to do this. It is a big surgery. And there is the highest rate of double therapy. So patients who need RPLND and then either require adjuvant chemotherapy for high volume metastasis or salvage chemotherapy. There are multiple series that have reported the results of primary RPLND. And you see here that approximately, well, they reported here 15% of teratoma in the retroperitoneum, and less than 10% chance of systemic relapse after RPLND, but very few patients die from germ cell cancer. All right, so then the last option here, we talked about surveillance, RPLND, and then the last option is primary chemotherapy or adjuvant chemotherapy. And the chemotherapy we're talking about is BEP. And the benefits of something like this is that you avoid unnecessary surgery. So there's many patients who get a primary RPLND who have negative lymph nodes, no teratoma, and they didn't probably need to have surgery. They didn't benefit from it. It's good for community centers, and I'm going to explain why that is. But this can be delivered consistently across any different hospital or medical practice. And it has the highest chance of cure with a single treatment. Problem is that you're giving chemotherapy that does have risks to everybody, and this overtreats at least half of the patients. And it doesn't treat teratoma. So a recent pooled analysis from a couple of years ago showed that if you give adjuvant BEP to patients with clinical stage 1 disease, that the relapse rate is less than 2%. So as opposed to 30 or 40% of patients who relapse on surveillance, about 2% of patients relapse after BEP. And if you compare a single dose of BEP to surveillance for everybody, you give fewer chemo cycles overall. Again, that's with the assumption that the patients who recurred on surveillance got full dose chemo as opposed to a mix of chemo and RPLND. So there was an updated, there's some updated studies on BEP. This was one published last year. So this is 246 men. They had a high-risk non-seminoma. All these are patients who had clinical stage 1B, who were given BEP, single dose of BEP. And their primary outcome was malignant recurrence at 2 years. Almost half, well, a little over 40% of these patients had some sort of acute toxicity. Usually these were, loss, decreased cell counts, leukopenia, etc. And similar recurrence rates as what the pooled analysis showed, a 4-year malignant recurrence rate of 1.8%. They did describe 3 teratoma recurrences, and this was with about a 4-year follow-up. So that overall, when you include malignant and non-malignant recurrences, there's about a 2.6% risk at 2 years. So, the question, at least my question is, and I think that BEP is a good treatment for well-selected patients. But one question that I think remains unanswered is that if you have, anywhere from 15 to 20% of patients with teratoma at RPLND, which is chemotherapy resistant, but you have a less than 2% risk of retroperitoneal relapse after BEP, what happens to all the teratoma in the patients treated with BEP? Is it that we haven't followed them long enough to see that these teratomas grow over time and will need delayed surgeries? I think that the longer term follow-up is needed in some of the BEP studies to really determine the long-term safety. But we talked about BEP being maybe preferable for centers who don't have experienced surgeons to do RPLND or community centers, and that's based on largely based on this study. This was a European study that was published in 2008 out of Germany. And 382 German men with clinical stage 1 non-seminoma were randomized to either ipsilateral templated RPLND versus BEP times 1. And this was done over 61 hospitals all throughout Germany. There's a moderately, about almost half these patients had LVI, which just kind of explains the overall risk of recurrence. And what they found was that the patients who had an RPLND had a higher recurrence rate than patients who had BEP. And that actually a lot of the recurrences after RPLND were retroperitoneal, maybe outside of the template, but in any event, both groups had 0 cancer deaths. So even the patients who recurred were salvaged. But this calls into question, if you're administering a treatment over multiple hospitals across a country, is RPLND really the best choice here? And potentially not. So that's one kind of important comparative study, and this is going to be this may be coming up on some of your tests. Another important study is from the Swinoteca group. So this is a Scandinavian group who has done a whole bunch of research on testicular cancer, and this is their published experience about risk-adapted management. And this, I think this makes a lot of sense, that certainly there's no reason to treat all patients with testis cancer the same way if you know that some patients are very high risk and some patients are relatively low risk. So here's how they did it. They divided patients into those with lymphovascular invasion and without. That was like their risk stratification tool. And for patients with LVI, they recommended BEP. And for patients without LVI, they either recommended surveillance or BEP. And you can see that on the LVI positive patients, the relapse rate was 0 to 3%, and which was similar for patients without LVI who got BEP. And then the approximately 13 to 14% risk of relapse in the low risk surveillance group is what you'd expect based on some of the other studies. So they said that with about 5-year follow-up, their cancer-specific survival was almost 100%. And this did come at the expense of some short-term toxicity with the chemo, which is what we talked about in the last or 2 studies ago. But there is a trade-off here. But overall, they thought this system worked very, very well based on these data. And they would argue that with this risk-adapted approach, it's better than surveillance for all or BEP for all, and it optimizes the number of chemo cycles per patient and the number of relapses. Overall, the mean number of chemotherapy courses was lowest for the risk-adapted approach compared to either BEP for all or surveillance for all. So, again, this is all about risk and benefits. So, clearly the benefits of BEP are that it lowers the recurrence risk to 2% or so, and avoids the need of surgery. But the question are, what are the side effects of this? We talked about early side effects being bone marrow suppression, et cetera. But what about the late side effects? This could be a whole talk in itself, but there's well-documented late side effects of having systemic chemotherapy, and these studies are all based on patients having chemotherapy for metastatic disease. So whether or not we can apply those findings to patients who having 1 or maybe 2 cycles of BEP, unclear. But just to mention this. The 2 main concerns of late side effects of chemotherapy are cardiovascular disease and secondary malignancies. So cardiovascular disease, there's a couple of studies that have described the risk of cardiovascular disease after treatment for germ cell tumors. This study from 2003 among almost 1,000 patients who were treated for germ cell tumors suggested there was about a 2.6% odds of having a cardiovascular event for chemotherapy compared to surveillance. And the 10-year risk of a cardiac event was 3.4%. The question is, well, if these are young men and this is a 10-year risk, what is the 30-year risk or 40-year risk? Similarly, this SEER study from 2015 suggested there was a nearly 5-fold increased risk of cardiovascular death within the first year of diagnosis. Secondary malignancies, this has been investigated a lot. This is a Dutch cohort of almost 6,000 testicular cancer survivors. And they estimated that the risk of a secondary malignancy at 10 years was about 10% overall. And patients who got platinum chemotherapy had a hazard for a secondary malignancy of about 2.4%. And their finding was that this was a dose response, so that more platinum is more risk. So this goes back to the question, does a single cycle of platinum have the same risk as 2, 3, or 4 cycles of platinum? Probably not. But I don't know if anyone can really quantify what the long-term risks of a single cycle of BEP are, or if there are any long-term risks. This is another Dutch a study from a similar Dutch cohort. Again, high risk of secondary malignancies for patients treated with chemo. And they actually equated the risk of either a secondary malignancy or cardiovascular disease for patients treated with chemo to as if they were smoking. So a similar risk factor as smoking was. All right, so then we've talked about these three things: RPLND, surveillance, BEP. You know, it's not totally black and white. There's a lot of right answers out there. And either way, the survival is nearly 100%. So I think this is really balancing over treatment, under treatment, risks, benefits, and you know what's important for some patients may not be important for others. So I do think that there's you know an element of shared decision making that's going to go into the discussion of anybody with clinical stage 1 disease. But we do have guidelines to fall back on here, and you can see that depending on the guideline, you know, where the guidelines from, whether it be U.S., European, etc., the recommendations are going to be slightly different. Everybody recommends that for patients with clinical stage 1A disease, so low risk clinical stage 1 non-seminoma, no LVI, we should survey those patients. Maybe a 15% risk of relapse on surveillance, but that is the widespread recommended treatment option. Now, the question is for the higher risk patients, what do we do for them? The Europeans recommend BEP. They don't like RPLND, in part based on that 2008 study, but they recommend BEP. And you know, the NCCN pretty much gives all three of these options for patients with clinical stage 1B. The AUA similarly recommends that for patients with clinical stage 1A, we should recommend surveillance for them. And similarly to the NCCN, for clinical stage 1B, patients with LVI or higher risk non-seminoma, we should either talk about surveillance, RPLND, or BEP. And this is shared decision making. This is, you know, a sometimes challenging conversation, but all three of those are reasonable options. All right, so we did non-seminoma. I've got about 20 minutes left. I want to get through seminoma, and then maybe have time for questions if there are any. So seminoma, slightly different disease and slightly different treatment options. So for seminoma, surveillance, primary radiation, and primary chemotherapy are all options. The disease-specific survival is about 100%. I hope that by the end of these next few slides, the answer will be a little bit clearer. I don't think there's quite as much controversy about seminoma. To you know, just cut to the chase, I think pretty much all these patients should get surveillance, but I'll show you why that is. So seminoma is unique because it's sensitive to radiation. There's no teratoma, and it actually is a little bit more difficult to risk stratify or to identify the highest risk patients. I'll show you why that is. So to first talk about surveillance, there's been a few important surveillance studies. They're actually the same ones that reported the non-seminoma patients, but this is the study from the multi-institutional study from 2014. 1,300 patients with seminoma, excuse me, 13% relapse. So this is a all-comer group, high risk, low risk, however you want to define that. 13% relapse, and that's, you know, the relapse rate is at least double that for non-seminoma. So you see this is a lower chance of relapse, and the patterns of relapse are also different. So whereas non-seminoma tended to relapse within 6 to 8 months, now we're talking about like a year and a half for seminoma. So it's a little bit of a slower disease. It takes a little bit longer to capture all those relapses, although 100% of these relapses were in the good risk category. And then almost all of them were detected on CT scan. And these patients were salvaged. So anyone who had a relapse of their seminoma either were given chemotherapy or sometimes radiation, and nobody died. This is another Canadian study that documented a 17% risk of relapse, and that if you, this is a figure that is demonstrating actually conditional risk of relapse, but point being is that if you make it by year 5, the chance of having a recurrence of your seminoma is less than 2%. So most of these recurrences happen early on, but it does take a little bit longer than non-seminoma. And for all other studies that have reported seminoma surveillance, almost 100% cancer-specific survival with usually a less than 20% chance of recurring. So, you know, just to kind of summarize this, almost all these relapses occur in the retroperitoneum. As with non-seminoma, not good for non-compliant patients. It takes a little bit longer for a recurrence to happen than in non-seminoma. So you might need to follow these patients a little bit longer than 3 years. Some have reported anywhere from a 5 to 10% risk of relapses after 3 years, which is different than non-seminoma. The AUA has a recommended surveillance protocol that you see here. Importantly, markers are not a routine part of this. And I think neither is chest x-ray. So that's definitely different than non-seminoma. So see the patient a couple times a year, CT scans periodically. You don't have to routinely do markers, and you don't have to routinely do chest x-rays, as it's pretty rare to pick up a seminoma recurrence on chest imaging where you wouldn't have otherwise picked it up on abdominal imaging with CT. So we talked about in non-seminoma about the fact that we're pretty good at identifying who's high risk and low risk for having a recurrence. But what about in seminoma? So this is from Canada, and their surveillance, this is from 2002, and they reported very good surveillance outcomes, high risk of survival, et cetera. But interesting with this study is that they showed us that based on their criteria, they thought that patients who had reedy testis invasion or a large tumor size had a significantly higher chance of recurring than patients without those. And so these are approximately twofold increased risk of recurrence. So this kind of led to the thought that, well, maybe we can identify patients with seminoma who are going to be more likely to recur. However, even the highest risk patients, okay, have a less than 20% chance of recurrence. So, the lowest risk non-seminoma patients have a 15 to 18% chance of recurrence. The highest seminoma risk patients have a less than 20% chance of recurrence overall. So, the argument against risk stratification here is that even high-risk patients actually have a pretty low chance of recurrence, relatively speaking. And this was a paper from 2018 that kind of tried to put all these studies together. Almost 10,000 patients with clinical stage 1 seminoma treated on surveillance. Over 75% of them overall were cured after orchiectomy alone, regardless of their risk factors. And they found that when they tried to do a meta-analysis of patients with large tumor size or reedy testis invasion, that they quote, the prognostic power of both tumor size and reedy testis is too weak to justify their routine use in clinical practice. They said that tumor size was associated with, it's a continuous risk, so there's not a definite cut point that should be used. And there's no standard definition of reedy testis invasion. And similar to non-seminoma, I think that the question about using microRNAs to better prognosticate patients who are at risk for recurrences, that's the next question. The AUA also does not recommend using reedy testis invasion or tumor size to determine the risk of recurrence for patients with stage 1 seminoma. So if a patient can't have surveillance or doesn't want surveillance, then the two options are either radiation or primary chemotherapy. So radiation is delivered, it's a relatively low dose of radiation, anywhere from 20 to, actually probably should be about 25 gray. Very successful at reducing the risk of recurrence. Almost never have an infield recurrence. It's very, very rare. Distant recurrence is anywhere from 3 to 5%. So because the infield recurrence risk is so low, you basically don't need CT surveillance, the retroperitoneum. Almost everybody who recurs can be salvaged with chemotherapy, and the risk of death is less than 1%. So similar to surveillance. There's a couple of important studies, and these come up on tests about radiation field, radiation dose, that are worth knowing. So this is a study it's an old study from 1999, and the question in this study was, when you give radiation, adjuvant radiation for clinical stage 1 disease, do you give it in a dogleg fashion, which covers not only the retroperitoneum here, but also the ipsilateral iliacs, or do you just focus it on the retroperitoneum? And so they randomized almost 500 patients to the dogleg versus para-aortic strip. Recurrence-free survival was almost identical. The difference is that there were slightly fewer pelvic recurrences with the dogleg field, which is what you'd expect, but increased spermatogenic toxicity. So that's the field question, dogleg or strip. The dose question, so here's a study of randomizing patients who are getting radiation to either 20 gray or 30 gray. almost all these patients had periaortic strips. And this was a non-inferior study, so they found that 20 gray was non-inferior to 30 gray, which you can see at the Kaplan-Meier curve here. However, there were differences in toxicity. So at 4 weeks, the 30 gray group had more lethargy and were less able to work. So higher toxicity, similar recurrence rate, that kind of led to 20 gray as being the preferred dose. So there have also been a couple of comparative studies with radiation. So one is, this is kind of an old study looking at RPLND, which people used to do, back in the 80s, versus radiation for clinical stage 1 seminoma. And this is not a randomized trial. This is an observational trial that they basically just changed their practice patterns over time, and they're reporting that. But they gave old radiation, a little higher doses, with cobalt radiation. I'm sure that these were more toxic. There's more toxicity, although they didn't report that. But they actually didn't report any in-field recurrences in either group, and a similar risk of out-of-field recurrences. So they actually used this to say that they probably didn't need to be doing RPLND for patients with clinical stage 1 disease. So another comparative study was using radiation or surveillance. So which is better here? This study, interestingly, looked just at patients who were at what they would consider the highest risk of recurrence, so the large tumor size greater than 6 centimeters. And this is also just an observational cohort study. And they found that in the highest risk patients, actually they reported about a 30% risk of recurrence. In the radiation patients, it was 2-3% chance of recurrence, which is what you'd expect. But overall, the surveillance group had fewer treatment episodes per patient than the radiation group. And the overall survival at 10 years was the same in both groups. So they actually used this information to suggest that surveillance is the preferred option, even for patients who had higher risk disease. So what about the toxicity of radiation? We briefly mentioned that with the 20 versus 30 gray study. So there's definitely acute toxicity for with primary radiation, bowel, hematologic, there's infertility. The late toxicity is probably the more concerning thing. And as with chemo, their chances of having cardiovascular disease or mortality or secondary malignancies are definitely higher for patients who've been treated with radiation. So you're taking a curable disease in clinical stage 1 non-seminoma, and potentially imparting a long-term risk of something that may be incurable or chronic in otherwise healthy young men. So this here really led to people rethinking the use of primary radiation for clinical stage 1 disease. And I would say that that is probably pretty infrequently done now, especially in the United States. The alternative to radiation for patients who can't get or don't want surveillance is single agent chemotherapy. So whereas with non-seminoma, we talked about giving BEP, which we know that cisplatin is very, very good at treating germ cell tumors. A single dose of it was shown to reduce recurrence rates tremendously. Well, people have asked the question about whether carboplatin could be used to reduce the risk of recurrence for patients with seminoma. And in fact, it does reduce the risk of recurrence in seminoma. We'll talk about here, this is a good test question here, that it actually may lower the risk of contralateral germ cell tumors. It's a good one to store away. So one important study actually randomized patients to either radiation or carboplatin. And this was a non-inferiority study. And so they had almost over 1,400 patients, and the primary outcome was relapse-free rate. And they found that the relapse-free rate with carbo is not inferior to radiation, which you can see illustrated with Kaplan-Meier here. And the carboplatin had fewer contralateral germ cell tumors. So, the authors here use this information to suggest that, carboplatin maybe is better than radiation, and we really shouldn't be doing radiation given the long-term risks. There's a group in Spain that has published numerous reports about kind of their own experience with this risk-adapted treatment. So patients with risk factors, which changed a bit over time how they define that, would get carboplatin, and patients with no risk factors would get surveillance. The most recent publication looked at the presence of either large tumors and reedy testes invasion as a risk factor. So patients with both of those would get carbo. And in the 2014 study, they found that the relapse-free, 10-year disease-free survival was lower as expected with surveillance. Still about 85% of patients were cured with orchiectomy alone. 97% were disease-free after carbo. All relapses were salvaged with chemotherapy. But kind of suspiciously and concerningly, if you looked at the highest risk seminoma patients, so those with reedy testis invasion, who have maybe a 20% chance of relapse, they still had almost a 10% chance of relapse with carboplatin. So, the question is that a meaningful reduction in recurrence? How effective is this treatment for the highest risk patients? Another study from the Swinoteca group had a similar protocol where they treated patients with risk factors with carboplatin and without risk factors with surveillance. And they found that, here, kind of surprisingly, the patients with risk factors who got carboplatin had a 9.3% chance of recurrence with carboplatin compared to a 15% chance of recurrence with surveillance. So I think, they labeled the efficacy of carboplatin as disappointing. And I think many others would kind of question how good is carboplatin if even in high-risk patients, the risk of relapse is relatively high compared to the risk of the relapse on surveillance. The other question is that with radiation, you sterilize the retroperitoneum, and so it's very rare to recur in retroperitoneum. But with carboplatin, in this kind of pooled study, you'd see that many of the recurrences were in the retroperitoneum. So you still have to watch it. You can't forget the retroperitoneum even after carboplatin. In patients who do recur on carboplatin, most of these are in the good risk group. Most of the time, this is in the retroperitoneum. Most of them can be salvaged with chemotherapy. So you're not necessarily increasing the risk of death from seminoma by treating with carboplatin, but it's questionable efficacy, but with a high salvage rate. So then finally here, let's talk about toxicity. Just like the Meg coming out to get a surfer there. There is acute toxicity with carboplatin, which we know well. It's toxic to the bone marrow, nausea, vomiting. People feel lethargic, kind of lousy. But this long-term risk question has been kind of unanswered. Up until last year, the biggest study, which was not very big, only 200 patients, suggested that compared to general population, there was really no higher risk of mortality, cardiovascular disease, or secondary malignancies in patients treated with carbo versus surveillance. However, an updated study from last year based on patient questionnaires actually identified about a 5% chance of a secondary malignancy in carboplatin treated patients, which they estimated to be about double the expected risk. So, we're going to have more and more, hopefully, information about the long-term risks of carboplatin, and that can help us, really quantify some of these long-term risks. But multiple people have written about what should we do for clinical stage 1 disease? Should we give carbo? And I think just to summarize a lot of these kind of consensus statements and expert statements, what they would say that for clinical stage 1 disease, we know that radiation is toxic. We know that it causes long-term risks of secondary malignancies and cardiovascular disease. There's not a lot of great long-term carboplatin data, which is still true. Even after carboplatin, you still need to watch the retroperitoneum. We don't know really how we should be risk stratifying these patients based on the currently clinically available risk factors that we have. And that even patients who you would consider high risk, the vast majority of them are cured by orchiectomy. So their punchline is that we should survey everybody with seminoma, and I would agree with that. I think that it's pretty unlikely, unless you cannot have this, you cannot administer surveillance, or if a patient is, going to be on a deployed or something like that for a long period of time, really surveillance should be offered. And the guidelines would agree with that. So NCCN strongly prefers surveillance, and the European guidelines also recommend surveillance. so do the AUA guidelines. So the AUA guidelines flat out state that we should offer surveillance for patients with clinical stage 1 disease, and that adjuvant radiation and carbo are less preferred. So with that, I am done, and I will 4 minutes to spare. Can I answer any questions?
Yeah, thank you, Dr. Anderson. That was an amazing. I really appreciate, I'm sure all the residents appreciate focusing on the management of just, the clinical stage 1 seminomas and non-seminomas tumor. One question we had was, and I think we've heard this several times in the lectures, the Empire series, with regards to management of clinical stage 1B disease. When people have talked about high volume centers and high volume centers have better outcomes, what exactly does that mean in terms of the number of operations for RPLNDs? Like, what is it 5? Is it 10? What does high volume mean
Right.
for better outcomes?
So I think that, most, if you look at some of the RPLND literature, most RPLNDs are done at low volume centers that perform like,
Yeah.
1 or 2 a year. And so clearly that's a low volume center. What is how many do you have to do? I actually don't know. I'd have to look back at some of those papers, but I would say that most high volume centers probably do anywhere from 10 to 20 a year, if not many, many more than that. And I think that that is instrumental in making sure that patients have a good outcome who are going to get RPLNDs. Certainly that's true for the post chemo setting, and those are much more difficult surgery. But even for primary, where you're talking about whether you do it open or robotically, however your approach is, you're talking about doing a pretty major surgery that does have risks, including risk of anejaculation, which is a long-term, sometimes permanent change in young, otherwise healthy men. So doing it right the first time is critical. And if a patient can't get a surgery like that, then probably primary RPLND is not the right answer for them.
Yeah, no, it makes sense. Dr. Margolin and Dr. Lasaya have very similar questions in regards to how do you counsel patients on future fertility, when it comes to whether it's prior to surgery, chemo, radiation, whatever. How does that play into decision making?
Right. So, I think in most patients who have a normal contralateral testicle who are going to get an orchiectomy, you don't necessarily have to do any sort of fertility discussion or sperm banking prior to orchiectomy. But in patients who are going to require adjuvant chemotherapy, RPLND, any of those treatments can impact fertility, whether it be due to anejaculation with RPLND or due to toxicity, to testicular toxicity from chemotherapy or radiation. So all of those patients in my practice have their sperm banked, at least if they're still planning on having a family one day. Some patients it's not important, but I do counsel everybody on that.
Okay, great. Well, in respect for your time, thank you